And that twitch response guarantees that you do have a trigger point, because we don't know of any other condition that will cause a local twitch response except a trigger point. And this helps to confirm it, although the critical thing is that that trigger point reproduces the patient's pain complaint. That makes it an active trigger point. A latent trigger point is a trigger point that does not cause the patient a clinical problem of pain. They're not aware of having a pain complaint. Although many times when you compress a latent trigger point, you can elicit its referred pain pattern. It will reproduce the referred pain pattern, which is what would hurt if it became an active trigger point, if it became more irritable. Here we see the baseline, quiet, no activity in the region of the taut band. Then we see the local twitch come into view with the quick action potentials. And then a secondary response as the pressure is released from the trigger point, and then it returns back to a quiet baseline afterwards.
The art of palpation is key to discovering the source of the patient's pain. Palpation should proceed gently through progressive tissue planes, allowing the examiner to discriminate between tenderness in muscle, other soft tissue, viscera, and bone. The examiner's fingers and the patient's response become a physiological unit, a constant feedback loop, gently probing, evaluating, reassessing. Trigger points in muscle bands are most effectively assessed by either flat palpation with the fingertips or pincher palpation, picking up muscle fibers between the fingers and the thumb and carefully looking for trigger points. An overall assessment will enable the examiner to establish a phase for the patient's myofascial pain.
Phase 1 of myofascial pain is constant pain all the time.